seated. Good morning, ladies and gentlemen of the jury. You guys seem in good spirits today. We're going to continue on. Mr. Zion or Mr. Husel?
That would be me, Your Honor.
Okay, Ms. Bucher.
Got it.
Call your next witness.
Thank you. The state would call Dr. Genevieve DeKeel.
Did you guys hear the name okay? She was away from the mic.
Dr. Genevieve DeKeel, D-E-K-I-E-L, for the record.
Okay. Just come on down. You gotta go through this little maze here.
Got it.
Okay, I need you to raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God? Okay? If you're more comfortable, you can lower your mask. Okay, I need you to have a seat, get comfortable there. You've got an aerial mic there in front of you, so you have to enunciate towards it.
Okay.
Okay, I need you to state your name and spell it for us, please.
Genevieve DeKeel, G-E, the first name?
Both.
Okay. Genevieve. Last name's DeKeel, D-E-K-I-E-L.
It helps my core report to get your diction, so that's why I do it. Okay?
Thank you. Good morning, Dr. DeKeel.
Morning.
Where are you currently employed?
I work for Columbus Inpatient Care. It's a hospitalist-based group out of Columbus, Ohio. We're contracted with 3 hospitals, including Mount Carmel, now Grove City East, and a rehab hospital in Westerville.
And what's your position there?
I'm a hospitalist. I round in the hospital, and that's my sole position.
And how did you come to be in that position, starting with your undergraduate?
Undergrad was at Florida State University. Florida State University.
Okay. To help us a little bit, doctors tend to talk faster than most people. It's okay.
Okay.
One of those things. So bear with us a little bit. She's trying to record what's being said. Okay?
I forgot she's writing everything. So Florida State University, biology major, chemistry minor, and then I went to medical school at Ross University, and then I did my residency at Mount Carmel, what was Mount Carmel West Hospital, for 3 years in internal medicine, and then I went straight to work as an internist, hospitalist is my title, at Mount Carmel.
And what are your duties and responsibilities as a hospitalist currently and since you've started at Mount Carmel?
Okay, so I work like a primary care doctor, what you would see your internist or your family med, but I'm internal medicine trained. So I work like an internist just in the hospital. My job would be admitting patients through the emergency department, taking care of patients that have already been admitted to the hospital floor, and discharging patients once they're ready to go home. And we provide 24/7 care, so my shifts vary between daytime, evening, or overnight.
Would you be what's called an attending physician?
Yes.
Can you explain what that means?
Attending physician just means that I graduated residency, just simple as that. I'm a full-fledged doctor, if you will.
And as part of your responsibilities of admitting patients and discharging patients, do you prepare death certificates?
I do.
Do you prepare discharge summaries?
I do.
Okay. What types of things do you do in order to prepare those documents?
I'll start with the discharge summary. Discharge summary is every patient needs one when they're leaving the hospital. So I'll go through my first step is last progress note. I take This is my practice. I take the top part called the impression from the discharge summary and essentially copy and paste that into my discharge summary and add on to it. So I'll go through the last few progress notes from the consultants that are on, any special or brief notes that have happened, and do a quick recap of the last few days or the full summary of what happened during the hospital, as well as the problem list, all the diagnoses that the patient's been diagnosed with during the hospital stay, the first one being the most immediate or why they were hospitalized, and a medication list at discharge, so that way the primary care doctor can pick up where I left off, and then anything that needs to be followed up on, so the primary care doctor it can be flagged for that person.
And what if the patient dies in the hospital? Do you still write a discharge summary?
Yes, every patient needs a discharge summary. It's one of the requirements.
And do you do anything different when preparing a discharge summary for someone who's deceased?
It may be a little bit faster just because the primary care doctor doesn't need to follow up on anything. So I'll still take that impression from the last progress note if the patient's been there for a while, and then just summarize saying what happened to lead to that person's demise.
Now let's talk about the death certificate. What do you do to prepare the death certificate?
Death certificate would be the time of death and the most immediate cause for what that patient died from. So I'll look over usually my last progress note and see why the patient was there, what happened for that death to occur, whether it was a cardiac arrest in the hospital, for example, and use an educated guess as to why that person died.
What do you mean by educated guess?
So going through all of the problems of why the person came, using my example as a cardiac arrest in the hospital. If a cardiac arrest happened, it could be a sudden cardiac death. I can use that as one of my problem list. If the patient was there for an infection, I might say, let's say, for example, severe sepsis due to urinary tract infection as my most immediate cause. But whatever the patient was admitted for and then what happened during the hospital stay that led to that person's death. Does that make sense?
I believe so. So you start with what they're admitted for, you said?
Yes.
And then you look through the notes?
And it might evolve. So the person might come in with one thing and die of another, but it's whatever happened that led to that person's death. That would be the first thing on the death certificate.
Okay. And is it ever the case that you will fill out a discharge summary or death certificate without ever meeting the patient?
A handful of times, yes. It doesn't happen often.
What situation would that occur in?
Where I would have to fill out a death certificate for somebody I've never actually laid hands on. If somebody came in to the hospital and I was supposed to do an admission of that patient and the person died before I was able to even go and see the patient just based on my rounding and patient load, there's sometimes less than half of a handful of times that I haven't been able to actually lay hands on somebody that has died. I'm assuming you're getting into this example.
So, well, first of all, do you admit patients into the emergency room?
Yes. Patients that come onto the floor would either be through the emergency department or a direct admission from home or from a doctor's office if they're stable. If they're unstable, everybody goes through the emergency department, and then I would admit through the emergency department.
Okay. Your Honor, may I approach?
Okay.
Thank you. For the record, I'm showing
Is there something? Here.
all right, I am showing,
Hold on.
sorry. All right, I am, for the record, showing the witness States Exhibit 7B and 7C.
Could you take a look at these for me, please? And just tell me what it is that I'm showing you. Starting with 7B.
7B. 7B is my discharge. Oh, actually, it's my discharge summary. It's my history and physical stapled together.
And for what patient?
Mrs. Jeremiah Hodge.
And what's the admission and discharge date there?
The admission and discharge date are the same day. It's April 1st, 2018.
Okay. I'll take that back from you.
Sure.
Can you please tell me what 7C is?
7C is a medication administration record of 2 medications.
And is this for the same patient?
It is.
And
Mrs.
during the
Jeremiah.
same time?
Yes.
Thank you.
Do you recall treating this patient?
I don't.
Okay. After looking at the discharge summary and everything, can you recall what happened with this patient?
Yes. Sorry, I guess I have to backtrack. I vaguely remember the situation. And then reviewing the records, yes, I do.
Okay. Your Honor, do you care if I publish the history and physical? Okay.
It's not working well with me. I guess the first spot, I can guess the second.
Go through Jones.
Okay.
If it's easier, Your Honor, I can just have the witness read it to herself and then
No,
explain.
as I explained to the jury yesterday, they're coming in Friday to fix all the little problems here. We're going to be dealing with this all day. I'd really take a couple minutes now.
Okay.
Do you have it turned on there?
It's on the TV screens on these, but I
Worked
don't,
up there first, and then it
Yeah, and then
stopped working there and started working on the street, so it's pretty off.
Are you actually able to see the dock
on the
on the
tables.
screen?
Yeah.
Because it's not on mine up here.
It's not?
Dun, dun, dun. This one's on me, guys. Since we're going to be using it all day, we might as well solve the problem now.
More than normal. Early.
And it's Paul. Good morning. It just doesn't seem like a morning without seeing you.
You know what they say about a day without sunshine?
Yeah. Okay, that's your new nickname, Sunshine. You picked it. You got it. Looks like it's got something going on up there. I brought the screen down from up here,
Okay.
and we had like private show up on there a couple times.
That's a good thing.
Well, it's just not getting it his home yet, but are we better to wait till a break and then let you do your voodoo, or?
No idea why it's not.
Well, that tells me we're gonna go without it, and you might want to bring the TV back. Of course, as soon as we go to break, it'll start working. Why don't we work without it? He'll bring the TV in, we'll hook it up for the jury so that you can show directly off the pad.
All right.
Okay? Thank you, Paul. I mean, Sunshine.
Your Honor, may I reapproach the witness?
Yes.
Thank you.
I'm going to go ahead and just show you the history and physical, that way you can read it real quick to refresh your memory.
Sure.
Once you've done that, just go ahead and hand it back to me.
I don't know what that is, but it's concerning because it sounds like it's coming from behind that door.
Okay.
Thank you. Does that help you to recall
To be honest, it was back in...
Hold on.
Oh, sorry.
Can I suggest some 3M oil?
Sorry, folks.
It was take them a minute, that way you guys can see what they're talking about. And you were worried.
Are you able to see that, doctor?
Yeah. Am I allowed to move to the end? Yeah,
Yeah.
no, this is good. Okay.
Just whenever you get away from the mic, you just gotta be a little directional.
Yeah, you can't see it in the corner.
Sorry. You might be able to blow it up a little bit.
Does that help at all?
Magnify?
Yeah.
Yeah.
Yeah, I can see it. Thank you.
Is that all right? All right. And is this the document I showed you just a moment ago?
Can you show the top part? Sorry. Yes.
And can you tell me just this top part here? Is this your entire discharge summary right there on the top?
This is, I will admit, this is a lazy version of a discharge summary, just basically because I've already said everything that needed to be said in the history and physical on my admission paperwork. So this is rather than reiterating the same thing and copying and pasting an entire portion, this is me just saying refer to the H&P.
Okay.
It's lazy.
Okay. And you say H&P, what do you mean by that?
Sorry. H&P is history and physical. Every patient that comes through the hospital, admitted to the hospital, needs a history and physical and a discharge summary.
All right. Is this the history and physical for that same patient?
Yes.
For that same admission date and discharge date?
Yes.
And you read through this just a moment ago, correct? Could you give me a summary as to what happened with this patient?
Yes, she was I think she was 57, I apologize. 57, Miss Jeremiah Hodge. She came into the hospital in full cardiac arrest. She was walking out to the car with family, and she suddenly passed out and lost pulse. Someone, I don't know the details, but someone, a bystander of some sort, started doing chest compressions on her while 911 was called. When EMS arrived, she had no pulse. They took over care, and they brought her to the hospital. She was still in cardiac arrest, meaning no pulse, when she arrived to the hospital, actively doing chest compressions. After a series of medications, continued chest compressions, she got a pulse back, and they did an EKG to see if anything was awry, and she had an ST elevation myocardial infarction, and big word just means heart attack, but the type that needs to emergently go to a heart catheterization to see if there's any blockages in her heart. So a STEMI alert was called, an ST elevation MI alert was called. The cardiologist came to the hospital, brought her to the heart catheterization lab, and they did a heart catheterization. They sprayed dye in her heart to see if there's any lesions or blockages that would amount to what happened to her, and they didn't find any. They just found a whole bunch of old changes, but nothing that was lack of any blood flow that would cause a heart attack. She still had a pulse at this point. They brought her to the ICU, the intensive care unit, and in the intensive care unit, she lost her pulse again. A code blue was called, where pharmacy, nursing staff, all the ancillary staff that you need during a code blue to attend to a patient came. Still doing chest compressions, and I think eventually they got a pulse back, and she was on a ventilator with all full-blown life support. And Dr. Husel had a conversation with the family about her poor prognosis, and the family decided to withdraw care. And that's when she was taken off the ventilator and had passed. And all of this happened without me seeing the patient.
So you had zero contact with this patient?
No, this is me just summarizing what happened during her brief, very brief hospital stay. This all happened in a series of maybe less than 2 hours, I believe.
So you wrote this discharge summary, correct?
Yes.
And if you didn't see this patient, how did you know what to write in the discharge summary?
I reviewed the notes, and between the emergency department notes, the squad notes that are scanned into the computer, the heart catheterization notes, the note from the cardiologist, and then notes from the ICU, either a brief note from the nursing staff or Dr. Husel's notes. And my job is to summarize at that point because I hadn't seen the patient.
Did you review the entire medical record from this patient?
Define entire, I mean, no.
Page 1 to page...
No, I would have no time to do that.
And did you review the medication administration record for this patient as part of your discharge preparation?
No.
I'm sorry?
No.
Okay, and why not?
It's not part of my, I would have nothing to gain from reviewing a medication administration record, the MAR. I would have nothing to gain from that.
And why do you say you would have nothing to gain from that?
Because she had passed, and my job is to summarize her hospital stay up until that point, and it's not my normal practice to review the MAR when I go through and do a discharge summary, just because it's relatively low yield. I have nothing, there would be no addition to my discharge summary based on that.
All right, and did you prepare the death certificate for Ms. Hodge?
Yes.
Your Honor, may I approach the witness?
You may.
I'm going to hand the witness State's Exhibit 18G. Can you go ahead and tell me what this is, please?
It's the death certificate for Mrs. Jeremiah Hodge.
And did you prepare this?
I did.
And did you sign off on it?
I did.
Thank you. Your Honor, may I publish? I don't believe there's any objections from defense.
No, we stipulated too early.
All right. So I'm showing 18G. And is this the death certificate that I just showed you?
It is.
And what is the cause of death that you list here?
Multi-organ failure.
And can you tell me the difference between the multi-organ failure that you put here and then the two other things below that?
Yeah, so I have to put in this, once again, it's an educated guess as to what happened. So my first diagnosis on a death certificate is what likely led to her demise as reviewing the records. And then it's due to, if I can come up with reasons or rationale, or secondary to. So multi-organ failure would be exactly what it says. It would be multiple organs have shut down because of. And then in her case, it would be because of cardiopulmonary arrest, the prolonged arrest that she had, where she was without a pulse for, I would have to count out how long it took for her to get to the emergency department when she lost her pulse outside the hospital, including the ones that happened in the hospital. And then probably due to, and this is all a best guess based on her labs that I have.
And why couldn't you just put cardiopulmonary arrest
Because it's always...
Arrest, I'm sorry.
Yeah, it's because it's due to something. So cardiopulmonary arrest doesn't just happen. I could put sudden cardiac death. I could have put that. But she had other things that I could go off of based off of her labs, I suppose.
Are there requirements of what you have to put in the death certificate?
Yes.
Can you tell me a little bit about that?
There's a whole published what you can and cannot write on death certificates. If something is due to something, you can't put it as your primary. I'm not really sure how I can explain that better.
So there are general restrictions on what you can and cannot put
Yes.
on a death certificate?
Yes.
What happens if you don't follow those?
It gets rejected and it comes back to me. So this is done online and it's very easy for me to do it. If you see it handwritten, the handwritten ones mean that somebody actually handwrote it and then submitted it to the funeral home, and then it goes to wherever it goes from there. But then it can be rejected and come back to me saying, no, it needs to say due to something. This makes it very easy since it's the electronic death registry system, and I can type out why the patient died and submit it right then and there, and then it automatically gets rejected and says, no, you need to write something different. So a lot of this is done for me. I mean, I have had some get rejected and I have to reinvent the wheel of why I think the patient died.
Okay. Thank you. Nothing further for this witness, Your Honor.
Mr. Lopez?
Do you want me to leave him up here?
Court, counsel. Morning, everyone. Morning. All right. Is it Dekiel?
Dekiel.
My last name gets butchered all the time. First thing I'm going to do is make sure I'm going to do it to you. Good morning, doctor.
Good morning.
Let's start off with the date in which you did these records for Ms. Hodge.
Okay.
That was in April of 2018, correct?
Yes.
And fair to say, in your role as a hospitalist at Mount Carmel, or with all these other hospitals, you see a large number of patients,
Yes.
especially between 2018 and now.
Yes.
Is it a fair assumption to say that absent having reviewed these records with the prosecution, you didn't have an independent memory of anything about Ms. Hodge?
Yes.
Okay. And then I believe after even reviewing the records, you said that you vaguely remember what had happened, right?
I remember the... Yes, I remember the evening, and I remember code blue going off, and that's all I remember. Otherwise, I have lots of patients that I have to also see, and yes.
Let's get into medical records. You'd agree with me that medical records and the things that are put in them are extremely important, right?
Yes.
Every progress note is important, right?
Yes.
Every consultation,
Yes.
every history and physical,
Yes.
every discharge summary.
Yes.
And they're important because they're relied upon by a number of people, right?
Yes.
The patients, if they are getting discharged and haven't passed away, they rely on that, right?
Yes.
Their primary care physicians can rely on that, right?
Yes.
Other doctors rely on it.
Yes.
Now, in fact, they're so important that even on direct, you mentioned that death certificates have a whole, I think you mentioned a book of policies where they can reject things if they're not done appropriately, right?
Yes.
And that just shows just how important these records and the death certificates are to everyone involved in these patients' care, right?
Yes.
Now, I understand you testified that it's not your typical practice to review the medical administration record, the MAR, right?
Yes.
But if you chose to, nothing would have prevented you from doing so, right?
No.
In fact, every medication she received is in her electronic medical record, which is accessible to you, right?
Yes.
Nothing's hidden there, right?
Nothing's hidden, no.
So everything that Dr. Husel did with Jeremiah Hodge was completely transparent to every physician, employee, nurse, pharmacist, anyone that had access to the electronic medical record of Mount Carmel, correct?
Yes.
Nothing hidden whatsoever.
No, nothing would be hidden.
Now, I understand that in preparing your history and physical and the discharge summary that you reviewed, you gave a long list there. I was trying to write it. The ICU notes, code blue notes, all kinds of stuff, right?
I'm sorry, yes. I said,
For Sam's sake, doesn't really translate on a transcript.
She caught herself. She's okay.
All right. Now, let's get into the history and physical, which I believe is State's Exhibit 7B. Now, you have to forgive me. I have to walk back and forth to make sure this whole thing is on there. Okay. Did everyone see?
You have a question?
I just want to make sure everyone can see it.
Okay, well,
It's
that's
hard without the screen to know what's...
Move on.
All right. Now, let's go piece by piece of this. I know you gave a summary on direct examination, but I want to get a little bit more specific about some things you put in your history and physical.
okay.
Now, first, you noted that she had a history of hypertension. That's high blood pressure, correct?
Correct.
Dyslipidemia, that's a cholesterol problem, right?
Correct.
CAD with stents, that means that she has a history of coronary artery disease, right?
Correct.
In fact, coronary artery disease is so severe that it required stenting to continue to remove blockage in her heart,
Previous stenting, yes.
indicating that she had had a history
Yes.
of heart problems so severe it required medical intervention at prior dates, correct?
Yes.
Now, that's the history she had prior to what happened where she had that first heart attack, correct?
Correct.
Now, when she arrived, she was found to be astolic. That meant she had no pulse, right?
Flatlined, yes.
Flatlined. And she was given 2 milligrams of epinephrine and remained without pulse with active chest compressions. Is that accurate?
Yes, I would have to review or go off of it because I don't remember the details, but yes, that's what I wrote, yes.
Okay. So epinephrine is a form of life support, correct?
Yes,
It's intended to bring your heart back.
yes,
And regardless of that first round of life support on the first heart attack, she still had no pulse and they were actively beating her chest as she was brought into the hospital.
correct.
Now, she's then given another milligram of epinephrine, 1 amp, is that correct?
Ampule,
Of bicarbonate and calcium gluconate. That's also life support, right?
yes,
So just to keep count, first heart attack, 2 doses of forms of life support, right?
What do you mean by 2 forms of life support?
The first time she received epinephrine, 2 milligrams, right? Still had no pulse.
I'm sorry, yes.
And then the second time she gets 1 milligram of epinephrine, she gets bicarbonate and calcium gluconate, right?
Yes,
So the first attempt to revive her with a form of life support didn't work and a second round was initiated, correct?
yes.
Okay. So,
Just to clarify though, there would be 3 rounds of advanced life support at this point. It says every round will get 1 milligram of epinephrine.
Okay.
So if you count out the epinephrines, that would tell you how many so-called rounds of life support. If you're using life support, I'm using, life support would work. We'll use that term.
please feel free to correct me. So we're at first heart attack, 3 rounds of life support then, right?
Yes.
All right. She then regains her pulse, but is found to be hypotensive, right?
Yes.
And then the pressors are started. Pressors are vasopressors, correct?
Vasopressors, yes.
And that's intended to keep her blood pressure elevated enough for her to live.
Essentially, yes. It clamps down on blood vessels that you don't need to survive and shunts that blood to vital organs that you absolutely need to survive if your blood pressure is low.
Okay, so keeping count, we're still at first heart attack, 4 different rounds of life support at this point, right?
I don't want to say heart attack because a heart attack implies that there's a blockage of some sort, and I don't know if there's a blockage of some sort at this point. She has no pulse for some reason, but I don't want to say heart attack because I don't know if it's an actual heart attack.
Fair enough.
Okay.
Her heart is not working.
There you go.
And she's
Okay.
had 4 rounds of life support at this point.
And a rest.
Okay. It's okay. One of the things is you both want to talk at the same time. I got to avoid that.
My husband says that too. And arrest is what the term I would use.
Okay. First round of arrest,
There you go.
fourth round of life support at this point, correct?
Correct.
She then lost her pulse again, and then is given another round of epinephrine. She's getting another round of epinephrine and aspirin, right?
Are you able to use a cursor to see where you are?
Yeah, let me just point you to it.
She has a pointer up there too, she can use that.
I know, I think she's asking me to point it out to her where we are.
I'm trying to follow him.
Okay. So,
Do you want to use this?
see where it says custody restarted?
Yes.
Okay.
Yes.
This is where we agreed that we're at the
Yes.
first arrest, fourth round of life support, right?
Yes.
Okay. She then loses her pulse again, correct?
Yes.
And then she gets another round of epinephrine.
Yes.
So we're at 5 rounds of
Yes.
life support, 2 arrests.
Yes.
All right. She then regains her pulse, right?
Yes.
Then we do what you mentioned, the heart catheterization.
Yes.
She's then started on Levophed drip. That's another form of life support, right?
It's probably the same vasopressor that was initiated in the emergency department. She was started on. That was probably a typo on my end. It should have said continued on Levophed drip. This is an assumption on my end. The emergency department.
I don't mean to interrupt you. Doc.
Don't do an assumption.
Bingo.
Got it.
Okay, whoa. Let's do a question, okay?
Does it say started or continued there?
It should say continued.
Okay. Regardless, we're at what? 1, 2, 3 arrests, and let's say, call it numerous rounds of life.
Numerous, yes.
There you go. Okay, she's then intubated for respiratory failure. That means that now not only is her heart failing, but her lungs are as well.
It kind of all goes together, yes. If somebody loses their pulse, the next step is putting them on a ventilator for life support. Yes.
Without your heart, your lungs can't work.
Yes.
Her body's failing,
Correct.
despite numerous attempts at life support.
Correct.
Resuscitation goes on from 1929, that's 729, right?
Yes.
Until 806.
Yes.
Roughly 37 minutes of after her heart stopping multiple times and numerous forms of life support, they're then resuscitating her for 37 minutes to get that pulse back.
You have to remember that there was also an arrest outside the hospital where chest compressions were started outside the hospital, and I don't have the time that would be on the ambulance report for actually when it all started.
No, I'm speaking to this in our timeline where we are here.
Yes.
So not the CPR that went on for a while before she got there. I'm talking about now where she's getting resuscitation efforts
Yes.
at the hospital.
Yes.
And this is after her heart having failed,
Yes.
her lungs having failed,
Yes.
and her having had multiple rounds of life support.
Correct.
She's actively dying despite numerous rounds of life support.
Sustained.
Is she improving despite these efforts with the life support?
No.
Okay. She's then brought back from the cath lab in PEA arrest. What does that mean?
Pulseless electrical activity arrest. It just essentially means that she might have, she has no pulse. She has no pulse.
So despite
It's an arrest.
EMS, the ER department, cardiologists, all these people attempting to resuscitate her, her heart keeps on stopping.
Correct.
And this is also, again, despite all the different forms of life support she's being given, correct?
Correct.
And then you speak to, initially, a code blue was called. Now, I know you don't have an independent memory as to what you reviewed in this case,
Yeah. Yeah.
but you indicated a code blue was called and that Dr. Husel was involved, right?
Yes.
May I approach the witness, Your Honor?
You may.
Showing that the witness was labeled Joint Exhibit 7, page 133. Without saying what that is.
Okay.
Do you recognize that to be a code blue sheet?
It is.
And this is a code blue sheet referring to Jeremiah Hodge, correct?
Yes.
It's the same code blue sheet you referred to in your history and physical there, where you referenced Dr. Husel, right?
Yes. I don't remember specifically looking at this when,
Can we approach real quick here?
Yeah. Ladies and gentlemen, get to know each other. I figured by now you'd know a little That's the issue.
Your Honor, I don't think there's a memory that can be.
Okay, you're done.
May I approach?
You may.
Oh my gosh, the signatures, geez.
Okay, just review it. Does that refresh your memory?
No, I didn't see it. I don't know. It looks like his signature, but I don't know. It looks like a W and an
Okay,
H.
stop.
Sorry.
Doesn't refresh his memory. Okay, go from there. Your doctor's memory.
Okay, so let's take it a step back. Dr. Husel was the ICU doctor that night, correct?
Yes.
Code blue occurred with Jeremiah
Yes.
Hodge, right?
Yes. It must be Dr. Husel that ran it.
Objection, speculation.
This is me using notes. Sorry.
Relax, let me do my job.
Sorry.
Okay? I'll permit it. Next question.
The code blue was successful, correct? Meaning the team that ran the code resuscitated her?
Can you put up the discharge summary or the history and physical again, just so I can look to see what I wrote? Yes, it was successful.
So Dr. Husel, and let me just take a step back. When a code blue occurs, it means that the patient is actively dying, correct?
Yes,
It's an emergency situation.
yes.
In fact, I believe you mentioned on direct examination that, actually, why don't you tell the jury all the people that are involved in a code blue situation?
Pharmacy for medication providing medications, nursing staff, a phlebotomist to draw blood, a doctor, multiple doctors maybe if they're on shift, several other ancillary staff, extra staff, if you will, to line up and do chest compressions. Each round is 2 minutes, so it gets very tiring. Multiple people need to tag in. That's usually the bulk of them.
And Dr. Husel's running that show, right?
Yes, in this instance.
Okay. And she was resuscitated because of Dr. Husel that night, right?
Objection.
Again, sustained.
She was resuscitated after the code blue, correct?
Yes,
She didn't die.
she did not die, no.
So Dr. Husel, running the code blue, resuscitated Jeremiah Hodge prior to the palliative extubation.
Yes,
And in fact, that was 23 minutes prior to the extubation, correct?
I would need to time it out. I'll take your word for it.
Now, this may seem like a fairly ridiculous question, but in your review of all these notes, and everything you did review when preparing this history of the physical, did you see any notes or anything that would give you any indication that Ms. Hodge angered Dr. Husel?
No?
Did you see any notes that indicated that Dr. Husel, for some reason, after resuscitating her, decided that he wanted to kill her?
No?
Objection.
Sustained. Ladies and gentlemen, disregard the last question and answer.
Thank you, Your Honor.
Did anyone tell you that she cut him off in traffic or something?
Objection.
Sustained.
Now, I understand that you said when you were doing your discharge summary and the death certificate that you referred to it as an educated guess.
Yes?
Nothing to gain from having looked at the MAR, right?
Yes.
Now, and that's because when you're reviewing,
Okay, identify for the record.
it's the same exhibit, Your Honor. Still showing the witness states exhibit 7B. Do you see that list 1 through 14?
Yes.
So you felt there was nothing to gain by looking at the MAR Because you looked at all these different things from all these different notes, correct? All the diagnoses.
I made those diagnoses based on vitals, her labs, and why she came into the hospital.
Okay, so you actually diagnosed these things. They were put in your discharge summary.
Some of them may have come from the emergency department physician and his documentation, but going off of any abnormals that I see on labs, that's what you're seeing for the diagnoses that you're seeing. It's a medical definition of any lab abnormality.
I'm going to show you the first page of your discharge summary,
Sure.
because it appears that the state's exhibit doesn't have the first page.
Okay.
I'll label this, Your Honor, as joint exhibit. Pardon me. Joint exhibit 7, page 6. This is where you actually put the active and final diagnosis, correct?
Yes.
Let me move that up a little bit. So this is where you actually put in your discharge summary the diagnosis that you made and others made as to what you believe was the cause of death of Ms. Hodge, right?
Yes.
Now, we're going to go back to how we talked about how important medical records are, okay?
Sure.
Now, I know you referred to it as an educated guess, and you felt that you didn't need to look at the MAR because there was nothing to gain from it, right?
Yes.
Okay, it's a compound question, start again.
It's just transitional, Your Honor, just to get to the...
I understand what it is. No.
She required life support, right?
Yes.
Despite that life support, her situation worsened, right?
Yes.
And that same situation is what caused her death, right?
Okay.
Objection.
Sustained.
You put as the final diagnosis all 14 of those things, right?
Yes.
And it's some of the same things that you put on her death certificate, correct?
Yes.
And that's because you need to put, and I quote from what you said on direct examination, whatever happened that led to that person's death on those important documents, right?
Yes.
So in your training experience, based off your diagnosis, those things...
Objection.
He hasn't gotten the question out.
Would you have put something on the discharge summary or death certificate?
Objection, speculative.
Okay, hold on. You scrap the first question, then I'll have to sustain on this. Do you want a sidebar?
No, Your Honor, I got 3 words to the question, so I don't know.
Well, one of
Wouldn't
those
put anything-
words was clearly objectionable, so.
You wouldn't put anything on a death certificate that you didn't believe was accurate as to a cause of death, right?
No.
Because it's important, right?
Yes.
Same thing with the discharge summary.
Yes.
And in fact, it's the most immediate cause of death you put on those documents, right?
Yes. For the death certificate.
For the death certificate. The document with all those rules, regulations, and potential rejection possibilities, right?
Yes.
Asked and answered.
One moment, Your Honor. Nothing further.
Redirect?
Yes, Your Honor.
So we've established already you have not read, or you did not read the medication administration record, correct?
I did not.
Just a starting off point, Your Honor.
Okay. Let's do, I'll let the question stand, but from now on, let's keep it proper terms.
When you wrote your discharge summary for Ms. Hodge, Were you aware that she had been given 800?
Objection. We need a sidebar for that?
Yeah. Hi, guys. Tell me when you're ready. I know, I'll wait on you. The objection is sustained. Ladies and gentlemen, you disregard the last question. Next question, please.
Thank you. Did any of the progress notes that you reviewed indicate any medications that had been administered by Dr. Husel?
I don't know. I would have to go back through and look at his notes.
Okay. So then, just to clarify, you did not review any of the medications that were administered by Dr. Husel to this patient?
No.
Ask and answer.
It was asked and answered, but let's move on.
Nothing further, Your Honor.
Okay, ma'am, you may step down. Thank you very kindly.
Thank you.
Call your next witness.
Thank you, Your Honor. The state's called Dr. Rohit Chand. Please stand. Go right up around here.
Come on down to the little obstacle course here. Come on up. I need you to raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but yourself to God?
Yes, sir.
Okay, why don't you go ahead and have a seat. You can lower your mask if you wish. Okay. Okay, I need you to go ahead and have a seat, relax. And I need need you to state your name. You got an aerial mic in front of you there, so state your name and spell it for me.
Sure.
That way my court reporter can hear your diction.
First name Rohit, R-O-H-I-T. Last name Chand, C-H-A-N-D.
Okay. You're a doctor?
Yes, I am.
Yeah, I've never known a doctor that couldn't knock that mic down. So let's get a little volume there, because these people have to hear you, and you're in kind of a fishbowl here. Okay?
No problem.
May proceed.
Thank you, Your Honor. Dr. Chand, where are you currently employed?
I'm employed with Columbus Inpatient Care.
All right, I'm going to ask you to speak up a little bit louder because I'm even having trouble hearing you. So could you repeat your answer to that,
I'm
please?
employed with Columbus Inpatient Care.
And what is your job title with them?
I'm a hospitalist.
And what type of education or training do you have to hold that position?
So after finishing medical school, I joined the internal medicine residency at Mount Carmel. After my training there, took my board exam for internal medicine, board certified, and then I joined Columbus Inpatient Care.
And where did you attend medical school, sir?
I went to medical school, Windsor University.
And when did you graduate from medical school?
I graduated in 2011, I believe.
All right, and from what we're hearing, there's a fellowship or residency first?
Correct, residency
And where did you do your residency at?
at Mount Carmel.
And what year were you licensed to practice medicine in the state of Ohio?
Well, when you start residency, you get your training license, so 2012 when I joined, and then when you graduate, you get your full license, so that was 2015.
And are there any continuing education requirements for you to maintain your licensure?
There are.
And has that licensure remained in effect since 2015?
It has.
Now, what did you practice your residency in?
Internal medicine.
And are you board certified at all?
I am.
And what are you board certified in?
Internal medicine.
And when were you board certified?
2015.
And has that been maintained since then?
It has.
Now, you use the term hospitalist. Can you explain to us what that is?
Hospitalist essentially.
We've heard the definition of hospitalist about 18 times.
Overruled.
Go ahead, sir, you can answer.
Essentially, as my colleagues have said, we're the primary care providers in the hospital. Essentially, we admit patients, take care of them on the floors, and then eventually discharge them.
Okay, so other than admitting patients, what else is part of your job duties as a hospitalist with Mount Carmel?
So essentially, when you're the rounding physician, our job is to round on the, essentially see all the patients that are admitted to the hospital and tend to their day-to-day needs.
Now, I note that Mount Carmel's hospital records has an attending physician listed for each patient. Tell us what that means.
Essentially, that would mean we're the go-to person for anybody who needs any assistance or information, or we are essentially like the quarterback. We're you know, if we need anybody on board, we get consultants on board, but we are the primary care providers, essentially.
And in 2018, were you performing the same type of duties as a hospitalist at then Mount Carmel West?
I was.
From January 11th of 2018 to January 14th of 2018, did you treat a patient by the name of Brandy McDonald?
I did.
And Your Honor, if I may approach the witness, I believe we have got this figured out to make life easy for everybody.
Okay.
Sir, I'm handing you what I've marked for identification at the bottom of your State's Exhibit 5C. Could you identify that for us?
This is a discharge summary.
And who's that for?
It's for Miss Brandy McDonald.
All right. And sir, I'm going to leave that up there with you, so if you need to refer to it, you're able to. And what I'm going to do is put on the big screen here for the jury. All right, and can you see what's on the big screen real quick, sir, at all? No. Let me see. This is difficult, isn't it? Can you see the number 5C at the bottom there, sir?
I can.
All right, and then at the top, what patient is that for? A little bit further down.
Brandy McDonald.
So is this what you have in front of you there, sir?
I do.
Okay. And what were the dates she was admitted into the hospital, sir?
Looks like she was admitted January 11th, 2018, and discharged January 14th.
And during that time period that she was in the hospital, did you in fact see her?
I did.
Do you remember her?
I don't.
Okay. Feel free to look at the discharge summary and see if that refreshes your memory, sir.
Vaguely, but I can see what I've documented here.
All right, what was Ms. McDonald in the hospital for at that time period, sir?
Looks like my partner admitted her after she was sent by her outpatient oncologist for essentially abnormal liver function tests.
Okay. And obviously, from this, does she have several diagnoses that you provided to her in the discharge summary?
Towards the end of the stay, once as her care progressed.
Okay. Before we get into her details, can you explain to us what you look at and how you arrive at your discharge summaries when you're discharging a patient from the hospital?
Progress notes, consultant notes, any pertinent imaging that was done, labs. That's pretty much it.
Okay. So in then creating the discharge summary, how do you go about doing that?
Same way, just review all those things that I mentioned.
Where would you derive the active or final diagnoses from in the hospital records?
From our progress notes, from ongoing progress notes from the day before.
Okay. And then turning to page 2 of that summary, Exhibit 5C, there's a part that is labeled, and let me double check this, hospital course. Can you explain to us what that is?
Essentially, it's a brief summarization of what occurred when she was in the hospital.
And can you give us a summary of what occurred with Ms. McDonald?
So according to this, she's, unfortunately young, who had metastatic ovarian cancer. She had multiple surgeries.
Okay, so I'm going to ask you to speak up a little bit and slow down a little bit.
Okay, so she's a 37-year-old female who came in with abnormal liver function tests. She had a diagnosis of metastatic ovarian cancer.
I'm going to stop you here. What does that mean to us?
Cancer of the ovaries had spread to all her or some of her organs.
Okay, go ahead.
Looks like she was on a clinical trial study for a chemotherapy agent because the traditional treatments did not work for her.
Okay.
So she was on trial with some medications that the oncologists were treating her as an outpatient. It appears that that's the direct reason why she was admitted, because the presumption was that the chemotherapy side effect essentially caused her liver function deteriorate.
Okay.
So she was admitted to the hospital for that. I consulted as my part of my job to get the specialists on board. So it looks like we consulted the oncologist. I believe gastroenterology was also consulted because the liver has to do with the GI system.
Okay.
She was started on some steroids to see if this would start healing her liver, and it appears that she continued to deteriorate. With that, she developed kidney failure. Then the kidney doctors were consulted, and eventually her respiratory, her lungs started to not function properly, so she was transferred to the intensive care unit.
Okay.
And it looks like she got intubated, so which means they had to place a breathing tube emergently to stabilize her. And there were talks about starting dialysis on her for her kidneys, just to do anything that we can to help her, but it looks like she did not tolerate dialysis. She actually started to require vasopressors, life support medication, on top of the ventilator. And then, the code status discussions were held, and eventually looks like her liver just went into fulminant failure. And then I guess she was palliatively extubated. So once it was discussed with the family, and then she passed.
So she had both liver issues as well as severe kidney issues at this point?
That's correct.
And I'm just going to move this up a little bit. Actually, I'm going to switch to the last page of the discharge summary and double check and make sure you can see it. What led to Ms. McDonald's discharge from the hospital? On the last page of the discharge summary, do you have that, sir?
Can you repeat the question?
What led to her discharge from the hospital, Ms.
Her
McDonald?
demise?
And that would have been in a court after her palliative extubation?
Yes.
Now, in looking at the records for your discharge summary, did you look at what medication was administered to Ms. McDonald during the palliative extubation?
I did not.
Would that be something that you would typically do?
I do not.
Why?
For a consented palliative extubation, there's no reason to believe anything of the sort. So we have a reason for why they're already there deteriorating, and that's the end of that.
So you would have no idea what medication was administered to her at the time they withdrew the vent?
I did not.
Now, sir, during your treatment, did you treat her during the time she was at the hospital? Do you recall?
Just reviewing the records.
Okay. So nothing else specific to that?
Nothing.
Now, for Ms. McDonald, did you complete a death certificate?
I did.
And I'm going to put up here what's been marked for identification. Let me see if I can see that up there. Can you see the number there?
Yes.
And what number is that, sir?
18E.
Okay. And this is a death certificate for which patient? I believe you have a copy at the back of your...
Yes, Brandy Lynn McDonald.
Okay. Now, tell us a little bit about when you are asked to fill out a death certificate. How do you do that, sir?
So death certificates come to us sometimes days after, so
Okay.
sometimes I could be off shift, I could be at home, and it looks like on this death certificate, this was a cremation.
Okay.
So when a cremation occurs, the funeral home is really pressed on time because they need this to proceed.
Okay.
Without this, they cannot proceed with the cremation. So you essentially briefly review the record of, and then come up with the diagnosis that you felt led to the demise.
All right, and we've heard a little bit of talk about this. What I see with Ms. McDonald is you have 2 lines filled out for the reason for death. Can you explain what this section means to us and how you would pick what goes in this section?
So the first line is immediate cause. So, I felt her immediate cause was, the reason she was admitted to the hospital because her liver was failing.
Okay.
And then why? And then another reason for her demise: metastatic ovarian cancer.
So, hepatic? Am I saying that correctly? What that means, the liver failure?
Correct.
And then the secondary cause would be the metastatic ovarian cancer.
Correct.
And again, when you're filling this out, would you look at the medication provided to Ms. McDonald at the time she was palliative withdrawn?
No.
Thank you, sir. I have no further questions. I mean, I'll leave these up here if I need them. And he's got his copy still, so that'll be easier. Thank you.
Please, court. So good morning. Dr. Shand, right?
Correct.
Doctor, I'm going to try and make this as brief as possible, okay? Doctor, I know you testified that you saw Brandy McDonald, but you don't remember her, correct?
Correct.
Actually, might be helpful. May I approach? This is just
You may.
progress now, so you don't have to go through this process. Doctor, fair to say you don't remember what you put in your progress note dated January 14th at 13:42 Eastern Standard Time?
I don't remember.
Would looking at that progress note refresh your recollection?
Which date are you asking for? Or just
It's
overall?
the first page.
For the first page, so for the 12th, you said 14th.
Okay, maybe it's not the first page.
He's got all of them, Mike.
I mean, I can go to the 14th. Yeah, that's fine.
Take a look at what's for the 14th and see if that refreshes your memory.
This is the 12th.
You know what, let's do it this way. Let's switch.
I have the 14th there.
Actual 14th progress note.
Sure.
Let's just switch.
Identify it.
Doctor, is your name on that document?
It is.
All right, what does it say at the top of the document? It showed you a different document, so we have to put on the record what was shown.
Sure, it's a progress note.
I understand, but in the top corner, there's some writing there. What does it say?
Joint Exhibit 5.
Okay, thank you.
Okay, doctor, is that a fair and accurate depiction of your progress note on the 14th of January that year?
Yes.
Can I have that?
Sure.
Commissioner Pellicciar?
Any objection?
No objection, it's his note, Your Honor.
Okay. Okay. This impression that's listed, that's your initial impression as to what was going on with Miss McDonald, correct?
Yeah, what you came to the hospital for.
Now, I can't see if it's, can you see the plan? Okay. Can you see that okay, doctor?
Yeah, it's a little fuzzy, but yeah.
Okay. And you indicated that during the course of her stay, she became very acidotic, correct?
Correct.
She was started on bicarb, that's a form of life support, correct?
Sure.
Then overnight, her respiratory status deteriorated, correct?
Correct.
You required an ICU transfer, and I believe you referred to it on direct examination as an emergent intubation, correct?
Correct, correct.
Now, do you recall what documents you reviewed to reach that conclusion you put in your plan regarding her having to be intubated?
I reviewed the brief notes that were previously entered by the night team.
Would you have reviewed the operative procedure document regarding that intubation?
I did not.
Okay. Are you aware who performed that emergency intubation?
I don't.
Are you aware that Dr. Husel?
Objection, Your Honor.
Sustained.
I would have to look through the records to see, because I don't remember.
The ICU is where that emergency intubation occurred, correct?
I wasn't present, so it could be on the floor, or it could be in the ICU. I don't remember if I wasn't there, so.
Who was the ICU doctor working that night?
Objection, Your Honor.
If you know, do you know who was working that night?
Dr. Husel?
Objection, it looks like he's guessing.
Well,
I'm
that's
just
a
saying
jury
because he kinda did
determination.
this.
I don't know the schedule. I mean, I'm assuming, obviously.
Objection, Your Honor.
Okay. No question pending. Strike the last answer there. New question.
So fair to say, regardless of who did it, she was on forms of life support, deteriorating, correct?
That's correct.
Required an emergency intubation, correct?
Correct.
And an emergency intubation is a form of a life-saving procedure, correct?
That's correct.
We don't know, you can't say who, but someone in the ICU at night did that.
Objection, Your Honor.
It's been asked and answered, yes, sustained.
Okay. This is, again, still referring to Joint Exhibit page 40, Joint Exhibit 5, page 46 and 47.
Is that the progress note still hanging?
Yeah, so it's the second
Okay,
page.
no problem. Just wanted to make sure.
This is still your progress note, right, doctor?
Yes,
And this is your assessment of her situation, is it not?
correct,
She's critically ill.
correct.
She's going to die.
Appears that way.
Poor prognosis.
Yes,
You met with the mother and father.
I did,
They didn't want heroic measures.
correct.
Palliative care consulted and the closed status changed, correct?
Yes,
So you took the initiative to speak to the family from Ms. McDonald, correct?
I did.
You delivered the news to them that her death was imminent, did you not?
I said she was critically ill and anything could happen, but I
You
didn't
felt
say
it. Oh, I'm sorry. I don't mean to talk over you. That's my fault, son. But you felt it necessary to have that hard talk with Ms. McDonald's family.
yes.
Now let's go to your discharge summary, which would be State's Exhibit 5C. Can you see there where it lists all the different doctors?
Yes,
That's all the different doctors that were involved in Ms. McDonald's care, correct?
some of them are partners with each other, so it doesn't necessarily mean every person saw them, but most of them did.
Fair to say you wouldn't have put them there if they had nothing to do with Ms. McDonald, right?
Correct.
Any one of these people tell you that they disagree with the fact that her death was imminent?
Objection, Your Honor.
Sustained.
Did any one of these people raise any concerns about the care that Ms. McDonald received to you?
No.
Now, the active and final diagnosis. This is where I believe you testified what you believe to be the cause of her death. Correct?
Correct.
Sorry, yeah, that head nods don't turn out on the transcript. Now, you referred to on direct examination as, or rather, when you were asked about why you don't review the medical administration record after, you use your term, consented palliative extubation, you felt it wasn't necessary, correct?
Can you repeat that?
You didn't feel it was necessary to review
That's correct.
the medical administration record during a consented palliative extubation, right?
Correct.
Now, to be clear, this is a terminal vent withdrawal, correct?
Correct.
Emphasis on the term terminal. Well, can you explain to the jury what the word terminal means?
Terminal means that all parties have felt it's the end of life situation. So at this point, it's just to proceed with comfort measures and just move forward.
And that comfort measures, are you familiar with what kind of comfort measures are used in palliative extubation?
Yes.
So that goes with saying that based off comfort measures, you're familiar with the doctrine of double effect, correct?
No.
Okay, so when comfort measures are administered, isn't it true that you're no longer treating symptoms?
Objection, Your Honor.
Sustained. We can have a sidebar.
What does comfort care mean to you?
Alleviation of symptoms, pain.
Okay. But you're not treating symptoms of underlying illness anymore, correct?
Correct.
And that's because to do so is futile at that point because death is imminent, correct?
Objection, Your Honor.
Sustained.
Why do you not treat the symptoms of the underlying illness as opposed to providing comfort?
Okay, you're asking for an opinion or you're asking for his practice?
In your practice, why do you treat, or why do you not treat the symptoms of an underlying illness and provide comfort at that point?
I'm not understanding.
In your practice, is there any point in treating symptoms of an underlying illness at the time of a terminal vent withdrawal?
No.
Why?
It's futile.
because death is imminent, correct?
Objection, Your Honor.
Sustained.
You don't feel that reviewing a medical administration record during a terminal event withdrawal matters, right?
You asked and answered that
It's
once.
a transitional, Your Honor.
Sustained. My own objection.
Why do you feel it's not relevant? Excuse me, make clear. Why do you feel it's not relevant when putting down these things in a discharge summary or what you put in a death certificate?
Because in general, like when when a patient comes in and we know what's going on, we have a reason for what's, what would be their cause for their demise. So when they reach that terminal point, there's no reason to go through, like I said before, consented palliative extubation and what meds were given to them.
Because you know at that point that their underlying illness.
Objection, Your Honor.
Sustained.
What happens when you remove life support from someone with the type of illnesses that Ms. McDonald happened to have?
You die.
Right? Quickly, right? Based off her
Objection,
conditions?
Your Honor.
Sustained.
Can you predict when someone's going to die when they're taking off life support?
No.
Could be moments, right?
Could be.
Minutes.
Could be days.
Don't know though. Could be from anything from a second to a week, right?
Sure, yes.
But what you do know is that when you remove life support from someone who needs it, they die.
Objection, Your Honor.
Sustained.
One moment, Your Honor. Nothing further.
Redirect.
Thank you, Your Honor.
Maybe can I close that progress now?
You have long because we're due for a break.
It depends on his answer. It may be a little longer than I would typically go, so we could do a break now, Your Honor.
Let's do a break. It's been a while. Okay, ladies and gentlemen, let's take 15 minutes. We get started at 5 till 11.
All right.
Have a great break. Enjoy the break, guys. Okay, Doctor, we're going to get back to you pretty quickly here. You're currently on the stand. You can't discuss your testimony. So if someone comes and asks you about how you testified, you're disregard the question. Understood? Okay, you can go on and out and relax for a second. Hold on, don't go too far. We're going to go on the record here. You can go now. Anything for the record?
Not at this time, Your Honor.
Nothing for the record.
You're not on the record. He is.
Nothing for the record.
Thanks.
I'm not trying to ignore you.
That's okay. You still weren't on the record. My face.
Oh, that was a question.
A demand.
Two guys.
No, one states, one states. Big difference.
I know. One of my favorite cookies growing up was my grandmother's tea.
Oh, yeah, Christmas time? They're fun to make, too.
They were one of my favorites.
Them and the kiss gumdrops. Peanut butter with a kiss in the middle.
They're good.
Why don't you get Paul here and see if you can do something with this? sunshine, does that mean he's darkness?
Not to her face.
You be sure to ask her how Judge asked how Rain Cloud was doing.
She would be so mad.
She would say, how did you find out my nickname?
I never say it to her because she would take that very personally. So closed.
I'm not sure it's a undried pig, but good nonetheless. Good.
This morning, and I was just like, let's not do that again. I could probably do two.
Are you still breathing there, Sunshine?
He's still fine. He's got the seal, isn't it?
Well, it's saying, it's just swearing here. Nothing. I have some yellow marks at the bottom. It's black.
Yeah, there's some yellow marks on this. I wonder if I touch it, does it get rid of it? There we go.
Are we going to be able to do the Zoom?
That's another question. Next.
What time will we do
back or the jury?
5 till.
Okay.
Looks awful dark there.
Yeah.
Does it still look dark?
Now it's light.
Now it's light. Can you see my house?
There we go.
Focus is horrible.
What's that?
Focus was horrible.
We put that
I
on.
do like the pink nail polish.
Oh, my.
Who's bugging you?
That's not good. That's not picking that up.
I thought Susan was crossing the line.
It's not picking it up.
What do you three want? Come on down.
Paul, it's not picking up the document. It's picking up the hand, but not the document.
Well, it's a focus issue, Paul.
Yeah.
There we are.
There we go. All right, whatever I touch, don't untouch it, right?
Thank you.
Thank you, Sunshine. I'm going to send out an email today that you're officially looking at the Sunshine. You're only here for a couple of weeks.
How many times have I actually
I'm getting ready to start back up. What do you guys want?
Just wondering if there was a really quick anything you told the jury I know about the mask rules? Anything?
Hasn't been anything yet. They pretty much have been doing their own thing.
I wasn't sure if anything changed.
Only the press has to be matched. Because you guys get out and about, so.
I feel like I'm doing something wrong. Okay, just was curious. Any?
All the signs are released from town. I do have the ability to force people to wear it, but. Well, there's a debate going on about that. My trouble with the jury, they would like the second row, front glass out, and I want the glass out in front of the witness so that you can hear this. And the order doesn't go into effect until tomorrow. So I'm in the process of negotiating that because supposedly I'm not here. I'm just even though I'm a visitor for the next one. You got to reserve for 3 months.
Long-term stay. You did the weekly, right?
That's what I told Alicia, I said,
Well, thank you. I just wondered if there's anything here. So pretty much just
I mean, they're the people that are here to get you an invitation. I'm like, you're retiring. What do you got? 13 days, 8 hours, and 14 minutes, right?
a modern, progressive, forward-thinking country.
Well, I was,
You know what, though?
I've still got 360 hours of vacation I can
Russians and Ukrainians.
You want to check it off, you're going to pay for each day.
take. That means the government takes tax trouble.
Well, you don't need anything else, because whatever you get, government tax, whatever you get. strikes, isn't that like forever in California?
What is that? 3 marriages, 4 kids, 6 grandkids.
Okay, guys, thanks. Yeah, please. Okay. I've got some in my car. Do you want to borrow it? It even has a little red jet little thing. Oh, if it's not one thing, it's another. Just relax for a second. They'll call everybody up when the jurors come in. Due deference, that's what we do, okay? And then at that point in time, I'll tell everybody to sit down, and then we'll go along with your testimony.
This is a generation of them. And I think proof God, he's just going to walk in and say,
You might as well gather them up. No, go ahead and go. We got 2 minutes.
I was just chit-chatting.
Okay.
I was going to explain why I need the tissues. I sneeze, then my nose starts to burn. And I'm like, I don't need tissues.
You want
And
me?
I can't, I wasn't going to do this. No, I'm in now. And now I haven't sneezed, except for that one time. But I can't sneeze. For sure, I don't think this girl. Classy. Classy.
This your daughter? Yeah, okay. This explains a lot.
I'm like, why don't you just wipe your face? Pictures.
When we fall, it'll be because of our own internal inertia.
Yes.
But, or whatever it is we do to ourselves, right? We don't have these external threats. Not really. I mean, unless there's some major miscalculation. This will start getting locked in this stuff. Other than that, there's really no existential threat.
Actually, there's 2 discussions. Question I want to share with Joe. And that's some discussion about whether or not it's going to be considered short-range tactical as either a threat or an answer there.
Yeah, well, then that will be our problem. Oh my God, that's just speculation.
Yeah, I mean.
Let's say that it really is.
Did you have fun back there?
I did. Delusions and derangement.
That's not happening. Just because he has doctor in front of his name, doesn't mean he gets his DUI.
Are you ready, Judge?
Yes, sir.
Judge?
Yes.
All right.
gentlemen, you can be seated. Ladies and gentlemen, the jury, I hope you had a good break. We're going to continue on with the testifying. Ms. Tharp.
Thank you, Your Honor. And Dr. Chand, I'm going to direct your attention to what was labeled by defense as Joint Exhibit 5, page 46 to 47. Can you identify this for us again?
It's a progress note, Brandy McDonald.
Okay, and I'm going to ask you again to speak up a little bit.
Progress note, Brandy McDonald.
And what is the date of this progress note?
The date is January 14th.
And what time did you make this progress note, sir?
Looks like just a little bit after in the afternoon.
And this would be the same date that she dies, is that correct?
I believe so, yes.
All right, so I'm going to direct your attention to the second page of this progress note that you discussed on cross-examination. The patient is critically ill, poor prognosis. Tell us what you did here.
Well, my main review, my main thing that I did here is really talk to all the consultants and really talk to the family.
Okay.
That was my main concern.
All right, and I note a palliative care consultant code status DNR-CCA. Explain to us what that is.
So I consulted the palliative care team to help us, but it looks like at this point, I mean, they didn't even see the patient. But I changed the code status after talking to the family to DNR-CCA.
What does that mean to us, sir?
The A means that after discussing with the family, that they understood she was ill, and we still would do everything to save her, essentially. But if her heart naturally stops on its own at any point, we would not perform CPR or any heroic measures.
And in looking at this note, it looks like you had discussions with the family regarding how long they wanted to work towards seeing if this patient could be saved or not. Is that accurate?
According to the record, yes.
And what was that time frame they were looking at this point?
24, 48 hours.
Is there in the Mount Carmel system at that time, Mount Carmel West, was there a different DNR code that could also be implemented? A DNR-CC, I think is what we've heard it called?
CC, correct, yes.
What does that mean?
That essentially means we're not treating anything significant, just focusing on comfort care, comfort measures.
So at this point, the family wants the treatment still?
Treatment still, but just no CPR.
Now, can you tell us, you said you consulted with all of the other doctors, am I accurate in that?
Yes.
And then you had the talk with the family. How do you typically approach this type of issue with a family in your practice?
Yeah, it's obviously a very sensitive topic. So first you ask the family if they want to speak separately or in front of the patient, and just kind of briefly go through everything that we said so far, which would mean imaging, labs, and then what, if any, summarize for them what the consultants would say or opinions of what they recommend, and then essentially give them how we may feel this may progress towards, and help them, guide them towards what would they want to do if XYZ would happen.
Palliative care consult, what does that mean to us? I know you said it didn't happen in this case, but if it had gone on longer, what would have happened?
Essentially a team that would do what I did already.
Okay.
Which was talk to the family and guide them through the process as far as prognosis and helping with anything and support and helping with the code status.
Is this type of conversation something that you would consider a serious matter?
A what?
A serious matter?
Yes.
Is it something you would do on an emergency basis?
Yes.
Why? Tell us that.
Because things sometimes happen very rapidly, and we prefer input from the family if this would happen. So they're not shocked and surprised that nobody said it, nobody told us anything. So they're just sort of informed.
Okay. And in this case, CCA is what the decision was?
Correct.
In your practice, Dr. Shand, have you ever performed a palliative extubation?
I have not.
Okay. All right. Thank you, sir.
Thank you.
I have no further questions.
You may step down.
Your Honor, I didn't open anything up on redirect that was already
Okay,
on cross.
stop. Ladies and gentlemen, talk amongst yourselves. Let's go sidebar.
So what do you do at the coroner's office on a day-to-day basis in general, if you can explain to them? We'll start with that. What do you do, and then we'll go into why you do that.
In forensic toxicology?
Yes, please.
Yeah, so I direct or lead a team of forensic toxicologists, and we perform a battery of toxicology tests on decedents, basically blood and urine, body fluids, to determine whether drugs or poisonings could have caused their death.
And how do you do that?
Well, we use a number of analytical instrumentation techniques. It includes gas chromatography, mass spectrometry, or liquid chromatography, tandem mass spectrometry. But these
wants to know how you get the samples.
Oh, I'm sorry. So samples or blood, urine, tissues are collected at autopsy or examination of a deceased individual, or they are subpoenaed from hospitals in the event a person was transferred to a hospital first.
All right, explain why the difference between the two, taken at time of autopsy versus subpoenaed from a hospital.
Yes, so it is standard protocol and actual required practice by the National Association of Medical Examiners for our investigators to subpoena and acquire samples at hospital admission. This is because while a person is hospitalized and remains alive, their body is continually breaking down and eliminating drugs. Therefore, that evidence of possible drug abuse would be gone by the time the person ultimately was deceased.
So what is your understanding, based on your training and experience, of how and when these samples of the person's blood, urine, and other things are collected? How is that done? When is that done at the hospital, based on your understanding and experience?
Blood samples are commonly taken at the hospital to do routine tests, typical blood tests or diagnostic tests to help a doctor diagnose a person's state or disease.
When they're first admitted?
First admitted, and then periodically throughout their stay in a hospital, physicians will order additional tests, maybe to diagnose a person's disease.
And for the purposes of your examination and based on the standards that you operate under, what blood and other samples do you want for your examination?
The first available sample closest to the incident that caused them to be transported to the hospital.
Okay. And is there a word for this type of blood as far as its time regarding death?
Yes, antemortem or before death.
So could you spell that for the record there?
ANTEMORTEM.
All right. And when you subpoena this, you want, like, when they come in as soon as they can, it's the soonest blood sample, et cetera, that they have, right?
Yes, those would be the closest to the incident that caused them to go to the hospital.
All right. And then I think you were getting into the scientific test that you're able to do on those samples.
Yeah, so once those samples are received and inventoried, they're barcoded so we can track their location and process as they're being tested. They are subjected to a routine battery of kind of preliminary screening tests, and then based on any presumptive findings, we'll follow that up with more specific confirmation tests.
All right. So were you so employed and so working back in April of 2017?
Yes.
And did you have occasion to examine the antemortem blood, that being the blood you just described, the first samples taken from a man named Ryan Hayes?
Yes.
Showing you what I had marked for the record as 18P as in Papa. Multi-page document. Do you recognize this document?
Just for the record, that states 18?
States 18P.
Okay.
Yes, I do.
And what is that document?
It is the coroner's report, findings of facts and verdict.
All right?
It is the autopsy report, findings and diagnoses.
And does that appear to be a fair and accurate copy of that document?
And it's also the toxicology
Hold
report.
on, we got an objection.
How could you authenticate something he didn't write?
Okay. We've been through this, overruled.
Go ahead, sir. Does that appear to be a fair and accurate copy of the autopsy report and findings?
Yes.
And is your report a part of that document?
Yes.
And where does your report begin?
On page 6 of this packet.
All right. And how many pages does your report contain?
5 pages.
All right. And is that fair and accurate regarding Mr. Hayes?
Yes.
Your Honor, at this point, I request permission to publish.
Only as to his report.
Correct.
Any objection if it's limited to his report?
Subject
Okay.
to his objection.
For the record, 18P attached as just described by the witness, the toxicology report. Is this what you were referring to up there, sir?
Yes.
All right, so tell us what's this at the top here? Who's Ani Ortiz?
That is the coroner of Franklin County.
All right. And toxicology, and who is Daniel D. Baker, chief toxicologist?
That's me.
All right, and who is this referred to over here? I'm pointing to the left-hand side.
Ryan E. Hayes is the decedent.
What's this case mean?
That's a unique number assigned to this case and this person.
And what's this mean over here on this side?
That's when the report was completed and issued.
All right. And what's this sentence mean here? Can you tell the jury what that means?
It means a full toxicology analysis has been performed.
Okay. And here we have that word again. What's that word?
Antemortem before death.
Okay, before death, blood. That's what you tested in this case?
Blood, yes.
All right. Lavender top bottle. What's lavender top bottle mean?
Lavender top just refers to the color top tube. Lavender tops contain an anticoagulant called EDTA.
All right. ELISA screen, what does that mean?
That's a screening test to screen for classes of drugs.
All right, let's go through the classes of drugs that were screened for. Acetaminophen, what's that?
Tylenol?
Was it detected?
No.
What's this next one?
Amphetamine's a stimulant. It was not detected.
What's this?
Barbiturates is a depressant. None were detected.
What's this?
Benzodiazepines are an anxiolytic or depressant. None were detected.
What's this word?
Benzoylecgonine is a cocaine metabolite. It was not detected.
Can you explain what a metabolite is?
Yeah, if a person or a human or animal for that matter ingests a drug or is exposed to a drug, the body breaks that drug down in order to more effectively eliminate it from the system or get rid of it.
And when it breaks it down, does it turn it into these other things called metabolites?
Yes.
All right. So no cocaine metabolite, benzoglycine, was detected.
None was detected.
What's this?
Buprenorphine is an opioid.
Was it detected?
No.
What's this?
Cannabinoids is marijuana. It was not detected.
What's this?
Fentanyl is an opioid.
And what was that?
We had a presumptive positive indication it may be present.
Tell them what that means, a presumptive positive indicating it may be present.
Because this is a screening test, like I said, there's a battery of screening tests that are performed, and then they're followed up with more specific confirmation tests. These are different and support maybe a preliminary indication that that drug may be present.
All right, what's this next one?
Methadone is another opioid.
Was it detected?
No, it wasn't.
What's this?
Methamphetamine is a stimulant. It was not detected.
What's this?
Opiates is a class of drugs.
And was that detected?
We obtained a presumptive positive.
What's this next? This next one here?
I can't read it.
Oh.
If you can move it up.
Sorry.
Thank you. Oxycodone and oxymorphone was not detected.
What's this next thing?
Salicylates, aspirin was not detected.
And lastly, here on this page, one.
Tricyclics or tricyclic antidepressants, none were detected.
Going to page 2 of your report. What's this at the top?
Okay, I can't see it.
Ah, you're right, Judge, you're right.
Ethanol or drinking alcohol.
And was that detected?
Yes, it was.
What about this?
Nicotine from tobacco was detected.
What's this?
Cotinine as a metabolite of nicotine, it was detected.
All right, so that is the body's breaking down nicotine, and we have the metabolite of cotinine?
Yes.
What's this next thing?
Morphine.
And was that detected?
Yes.
And why do we have here, it's just been before, we've had measurements or confirmation. Why do we have a measurement here?
Yeah, see, on the left-hand column, you'll see the analytical technique. All of those are conformational tests.
Okay.
GCMS, or gas chromatography mass spectrometry. And yes, we confirmed the presence of morphine at 83 nanograms per milliliter in that blood sample.
All right. So these are the confirmation tests. The first page of your report were the screens. Now we're getting into confirmation tests.
Yes.
All right. What's the next thing that was tested for in the confirmation tests?
6-monoacetylmorphine is a heroin metabolite. It was not detected.
Next.
Codeine is another opioid related to heroin, and it was not detected.
Next.
Hydrocodone and dihydrocodeine are opioids, and they were not detected.
Next.
Dihydrocodeine is a metabolite of hydrocodone. It was not detected.
Next.
Naloxone is the antidote to opioid intoxication. It was detected at 26 nanograms per milliliter in that blood sample.
Hypothetically, if this person was given naloxone in an ambulance to the hospital, would that account for that finding in your confirmation reports?
Yes.
And tell the ladies and gentlemen of the jury your understanding of why naloxone is given and what its effects are.
Well, naloxone is given routinely now because opioid-related deaths are so prevalent. This naloxone blocks the opioid receptors and causes the opioid in the person's system not to have an effect anymore.
Okay. All right. The next section, what does this mean? Blue top blood taken on 4/2/17 at 1:41 a.m.
That was another blood sample utilized. It, I believe, is the same time and date as the other blood sample. What happens is hospital samples, a lot of times there isn't much volume there. So as we run out of volume in one sample, we need to go to another one and proceed with our testing and confirmation.
All right. Why did you test for alcohol again?
That was to confirm the presence of the first sample.
Confirm this one up here at the top?
Yes.
All right. And to give people a perspective, 0.10, is that like what people might be familiar with breathalyzers, things like that, OVI?
Yeah, 0.08 is the legal limit, so that is just over 0.08.
Okay. And then what else is confirmed here?
We confirmed fentanyl at 1.1 nanograms per milliliter.
All right. What's this next thing?
A norfentanyl is a metabolite of fentanyl. We did not detect it.
All right. What's this last thing here?
Carfentanil is one of the strongest opioids known. You may know this as an animal tranquilizer. It's not used in humans and is an illicit form of fentanyl.
All right. And this is taken prior to any hospital. This is taken when he gets to the hospital. So if this is in his system, this is something he's illicitly taken prior to arriving at the hospital.
Yes.
All right. Why don't we have an amount?
We do not quantify carfentanil just because its mere presence is significant enough to cause a person's death.
All right. What's next?
All of these tests, this next battery test is performed in the vitreous humor fluid, which is fluid obtained from the decedent's eyeball. All of these are metabolic or clinical chemistry tests and are used for the purpose to diagnose diabetes, kidney failure, or liver failure.
All right. So I'm hoping that is postmortem?
Yes, it is postmortem.
All right, because they actually, yeah, because it's from someone's eyeball? All right. Let's talk about the last page here. What is this?
Move it down just a little bit.
Oh, yep.
This was testing performed in postmortem urine from the decedent, and we tested a gray top urine sample, and we only detected cotinine, the nicotine metabolite, by GCMS in this sample.
All right. So the blood samples that confirm the amount of fentanyl, and in this case, carfentanil, that's taken as he gets to the hospital. That's the purpose of this.
Correct.
All right. Why are you doing these things, and how are they used by the coroner in determining cause of death?
The forensic pathologist, they use three main types of information to come to an opinion as to a person's cause and manner of death. They first review...
Your Honor, he's not a forensic pathologist.
I would agree, sustained.
Do you have an understanding of how your reports are used? Why are you employed? What do they do with your report? Do you have an understanding of that?
Yes, I have a general understanding.
And I'd ask him to be able to testify as to his general understanding of how his reports and his work is used by the forensic pathologist.
Okay. This is his understanding, though.
Correct.
Okay, go ahead.
In general, the forensic pathologist looks at three main areas of information. Number one is the circumstances surrounding a person's death, the scene investigation, or medical history. The second is their autopsy findings of disease or trauma. And the third piece of information is toxicology results that would substantiate or refute any type of drug or poison in that person's system.
Ante-mortem, has they arrived at the hospital?
Yes.
Thank you. Showing you what I've marked as State's Exhibit 18-0 has an Oscar. Do you recognize 18-0?
Yes, I do.
What is 18-0, please?
This is the coroner's report, findings of fact and verdict of James Timmons. The post-mortem examination report, findings and diagnoses.
And is a toxicology report part of that report?
Yes.
And did you perform that toxicology?
Yes, I certified the report.
And is that on the back of that, is that report contained therein?
Yes.
And is it fair and accurate?
Yes.
May I publish it?
Any objection?
Same subject, same objection.
Okay. Overruled. You may publish.
Now, you said when they come in off the street, they take the blood samples and stuff at the time of autopsy, but when they come in from the hospital, like Mr. Ryan, they take it ante-mortem as they arrive at the hospital. What's the situation with Mr. Timmons?
Both are accurate. So samples are not only subpoenaed and acquired from the hospital, but other samples are taken at the postmortem examination.
Okay. Were these samples that were taken, that were tested by you on Mr. Timmons, were they ante-mortem taken at the time that he arrived at the hospital?
Thank you.
Sorry, yeah, you got to look at stuff here. I'm sorry. Look, publishing page 1 of 5, the attached toxicology report that was just authenticated.
Yes, this shows that ante-mortem blood from James Nicholas Timmons was tested.
On what, and the sample was collected on what date and time?
October 22nd, 2018, at 21:47 hours.
All right. And just, we'll go through this very quickly. Same type of screenings as Mr. Ryan on page 1.
Yes, the ELISA screening tests showed a presumptive positive for benzoylecgonine, the metabolite of cocaine, and marijuana.
All right. Are any opioids in his ante-mortem blood, I mean, when he arrived at the hospital? On page 1 here.
Not on page 1.
Okay. So the screens are positive for a metabolite of cocaine. What does that tell you as a forensic toxicologist regarding his ingestion of cocaine at some point?
That individual was exposed to cocaine prior.
And his body
to
is
the collection.
processing it, and that's what's found?
Yes.
And the cannabinoids, that's just marijuana, however he took it?
Correct.
All right, going to page 2. Same test as we saw with Mr. Ryan. At the top there?
Yes, these conformational tests, ethanol was not detected, fentanyl was not detected, norfentanyl was detected.
What's norfentanyl?
It's an inactive metabolite of fentanyl.
All right, so once again, as a forensic toxicologist, what, if anything, can you surmise from Mr. Timmons at some point prior to coming to the hospital, his ingestion of fentanyl?
That he had been exposed to fentanyl.
And his body's breaking it down, and that's what's left?
Correct.
At the time he arrives at the hospital. Okay. And then what's the rest of these tests here in the section pop? Gold top serum, what's that?
That is another hospital antemortem sample. Again, just a different type of blood tube. And it's similarly, what is occurring is we're running out a sample from the gold top serum and going to another gold top serum.
All right.
This is at a different time.
A different time at the hospital?
It's 2 hours later, yeah. Or
Okay.
approximately.
So we see ketamine. What is ketamine?
Ketamine is a dissociative anesthetic administered to people for the purpose of medical procedures and, to anesthetize them. So
All right.
they're not aware.
So can you surmise, based on your training and experience as a forensic toxicologist, knowing that he came from the hospital, that they had begun therapeutic administration of drugs at this point?
Speculation.
Based on his training and experience, Judge.
Okay, we don't do runnings. Let's rephrase the question.
What, if anything, can you surmise, based on the timing of this and your knowledge of these drugs, how the ketamine got in there?
Objection, speculation.
This is our law to make inferences, Judge.
Can't guess.
I understand, okay? This is according to his training.
Yeah.
Okay, it's permissible.
From this report, the only thing that can be surmised is that this individual was exposed to ketamine sometime prior to this blood sample being taken.
All right.
We have access to medical records, and in the medical records, I know that this individual was given ketamine prior to this sample.
Okay, overruled.
Thank you. Moving on to the next section. What do we have here in the gold top serum sample 2332? Is this a different time? Is that what that is saying?
A different time from what?
From the one that we just looked at?
Yes, it is.
So you're running out of samples, and as the hospital continues to take samples, you're continuing to test?
Yes.
All right, so what do we find now?
We only find 11 nor 9-carboxy delta 9 THC, an inactive metabolite of marijuana.
All right. Now, down here, antemortem urine. So this is before death urine. So we're out of the blood. Now you're looking at Mr. Timmons' urine that was collected at this date and time?
We didn't go to the urine because we were out of blood. We test blood and urine on every case if it's available.
All right. And what do you find testing his urine that was collected on 10 down
Yes.
the ketamine? All right. Finally, moving to page 3 of your report. What else do you find in Mr. Timmons' urine?
We see your hands on it.
Oh, there we go.
Cocaine and its metabolites benzoylecgonine and methylecgonine.
All right. And once again, are there amounts here? Like how much is in the system?
Not in the case of urine. Those urine results, the amount is not interpretable.
All right. You can just say it's there or not.
Exactly.
So, doctor, based on your training and experience as a forensic toxicologist, for how many years now at the coroner's office?
Since 2007. And I'm a forensic toxicologist. I'm not
What did I call
a
you?
doctor.
Oh, I'm sorry. I think I called you. I thought a forensic toxicologist. Under what circumstances do patients or do blood samples come to you as part of an autopsy? Are you aware of what circumstances?
Routinely on every case.
Everyone that dies in Franklin County gets an autopsy?
No, but everyone who dies and has an autopsy or an examination by a forensic pathologist, they obtain postmortem samples for toxicology testing.
And what is your understanding of why someone would receive why someone's body would receive an autopsy? If you know. If you don't know, that's fine.
That's determined by the forensic pathologist who manages the case.
Okay, sustained.
Move to strike and have a
We'll
witness.
strike the answer.
Objections to not.
Okay, stop. Strike the answer. New question.
Do you know how the determinations are made?
That's up to the pathologist's judgment.
All right. Thank you. I have no further questions.
Cross.
Mr. Baker, when did the state of Ohio tell you you're going to be called as an expert witness in this case?
I believe 3 weeks ago.
3 weeks ago. Did they ask you or provide you with additional materials to review prior to testifying?
No.
So simply just the report that you have here, correct?
Yes.
Okay. Now, let's go into your report for Mr. Hayes, which would be State's Exhibit 18D. Okay. Now, for Mr. Hayes, the first blood taken was on April 2nd, 2017 at 1:41 in the morning, correct?
That is not necessarily the first blood taken. That's the first blood that we received that was closest to the incident that caused them to go to the hospital.
Okay, so just to be specific, this is the first blood listed in your report that you analyzed?
Yes.
Okay. And so you're aware then that Mr. Hayes died the following day, not on April 2nd, right?
I know that some time period had passed since his admission and the time that he died.
Okay. But you reviewed
If it's a
the
day,
you reviewed the medical records, right?
I can tell you exactly. Well, it's actually in this exhibit, the date and time of his death.
Stop. Let's start with another question.
So, just to confirm again and not to waste everyone's time about this, fentanyl and opiates were confirmed to have been in that first blood you analyzed, correct?
Those are presumptive positives that you're pointing to.
Presumptive
That
positives.
gives us an indication that fentanyl or opiates may be present.
Okay, but that's why you do all these other tests, right, to confirm it?
Yes.
Okay, so based on these other tests, again, it was confirmed that he had fentanyl in his system, right?
Yes.
And that was when he arrived to the hospital, the blood that you analyzed, right?
Yes.
So he walked into the hospital with these drugs in his system. Actually, let me clarify. He was taken in an ambulance after overdosing on these drugs to the hospital, right?
I'll permit the question. Do you not?
I know that this death was presented to our office as a suspected overdose.
Okay. Without getting into what other people said, because you reviewed the medical records, right?
Objection, Your Honor, that's what other people said.
Okay, well, he's excluding it. Do you have a question?
Yeah. You reviewed the medical records, right?
I reviewed the medical records.
Yes or no?
In light of
Mr. Baker. Yes or no? Did you review?
He's answering your question. Go ahead.
While that is correct that I reviewed some medical records, I reviewed the medical records specifically to substantiate toxicology findings by our scientists.
Okay. So then you would be aware then that he came to the hospital as an overdose, right?
That's how the case circumstances were presented to our office.
Okay.
That's what was suspected.
Now let's talk about carfentanil. I know you spoke on direct examination about how powerful it is, right?
Yes, it's
so powerful that the mere presence of it, you don't have to quantify because it kills, right?
It can lead to death, yes.
And that's why you don't quantify it when you test for it, right?
Correct.
Okay. In fact, as a toxicologist, you know that carfentanil is almost 100 times more powerful than non-illicit medicinal fentanyl, right?
I've seen various estimates.
Over 100 times, right?
Over 100 times more potent than fentanyl? Yes, I would agree to that.
Thank you. And again, that was in his system when he arrived to the hospital.
Yes.
As well as ethanol, right?
Yes.
As well as morphine, right?
Yes.
So to clarify, morphine and carfentanil are opiates but different drugs, right?
Correct. Carfentanil would be considered an opioid. Morphine would be considered an opiate.
Oh, let's talk about that.
Okay.
Let's talk about the difference between an opioid and an opiate. An opioid is synthetic, right?
Traditionally, opiates are termed that way as coming from the poppy plant or derived from the poppy plant. There are many other opioids that are synthetically derived, like you say, but there are some synthetic opioids that cross-react with our ELISA assay as an opiate. So they're very closely related, but they both work on the same receptors in a human.
They weren't different. Would they call them something? Would they just refer to them all as opiates? Maybe make it simpler. Why is there even a distinction between an opioid and an opiate? Because they're different, right?
For our purposes, they're different. Opiates or opioids react on different screening tests in the toxicology lab.
Are they the same
That's
thing?
why.
Simple enough. Are they the same thing?
Your Honor, I would object to him interrupting the answers and rejecting other answers.
Okay.
There is overlap in the definition. This is
But they're
why.
not the same thing.
Well, an opioid can be an opiate, but traditionally by a definition, opiates are derived from the poppy plant.
All right. Yes or no, are they different?
I believe there's overlapping in the definition when you categorize specific drugs.
In your experience, are they different?
Mayor, I think he's answered the question best he can.
I think he hasn't answered the question once.
Okay, move on.
So, okay. Getting back to the opiates and opioids that were in his system, there were multiple in his system when he arrived at the hospital, correct?
Yes.
Thank you. Let's talk about Mr. Timmons. This is State's Exhibit 1810.
O is an Oscar.
18-0 as an Oscar. And again, everything you reviewed for Mr. Timmons prior to his death, correct?
I didn't understand the thrust of your
All the
question.
blood you reviewed was prior to his death, correct?
All the blood that we tested was prior to his death. Reviewed, I reviewed and certified results,
Okay,
sir.
just relax.
Okay.
So you're aware then, in 1022, and having reviewed his medical records, you're aware then that he died days later, right?
Yes.
Okay. And you're also aware that he also came to the hospital as an overdose, right?
That is what is suspected, yes.
That he was found unresponsive by a family member after having been down for some time. You're aware of that, right?
I don't have the case memorized. I can review, the records of the case and tell you the specific circumstances that he came into our office.
I thought you reviewed them before you testified.
I did, but I didn't memorize the circumstances of every decedent, sir.
So you didn't care to memorize the situation when an overdose victim came in?
Okay, you're getting argumentative, let's move on.
What records did they give you to review?
They gave me these exhibits, but I have their full case records here, and I can tell you and answer whatever questions you want from me.
Okay. But as you stand here as a state expert, you're not prepared to testify as to the condition these people arrived at the hospital.
Form of the question.
It's not
No,
that at all.
Form of the question, re-ask.
Are you aware, as you sit here today, of the conditions in which these people came to the hospital prior to your analyzing the blood that was given to you?
Yes.
So then you're aware that both came to the hospital having been found unresponsive as overdoses?
As suspected overdoses, yes.
Okay, and that was prior to getting to the hospital, correct?
Yes.
Okay. Let's talk about what Mr. Timmons overdosed on. Now, the benzo, I'm not going to try and pronounce that. That was the cocaine metabolite, correct?
Correct.
Cannabinoids, marijuana, right?
Yes.
Okay. Now, you have the metabolite for fentanyl.
Correct.
Okay, and this is again prior to him getting to the hospital, or the first blood that you analyzed here, right?
Yes, prior to his death, yes.
Okay. And you said that based off your review of the medical records that you came to a determination that he was given ketamine upon his arrival, right?
Yes, that's documented.
Okay,
There in the
so
medical
tell me how
record.
that makes sense. Ketamine is used for sedation, right?
I'm not a medical physician. I don't know why it makes sense whether he was administered ketamine or not. I have the medical records that shows the date and time it was administered, and I can show you those.
So just to clarify, though, you didn't just testify in direct examination that he was given ketamine for therapeutic reasons? But now you can't talk about it?
I never said therapeutic reasons, I don't believe.
Your Honor.
So, overrules right now.
Who gave him the ketamine? You know that?
Not off the top of my head.
What's this meth thing here?
Methyleconine, it's a metabolite of cocaine.
Okay, so another metabolite for cocaine, right? And then we have your confirmation tests, right?
Those are urine tests, GCMS tests, yes.
Okay. Fentanyl, right?
Correct.
Ketamine,
Yes.
various forms of ketamine.
Metabolites, yes.
Cocaine,
Yes.
and the metabolites for it as well, right?
Correct.
As a toxicologist, you learn the effects of drugs on people, correct?
Yes.
People who use the drugs that James Timmons and Ryan Hayes use develop tolerances to them, don't they?
Can you repeat it? I didn't hear you.
People who use opiates develop tolerances for them, don't they?
Objection, Your Honor.
If you can answer.
Yes, they can after prolonged use, but that is reversible. So there's no way to know whether this individual had tolerance at this time.
Well, but you review the prior medical records, right? So you know that they both have documented histories of substance abuse.
Okay, sustained.
Are you aware that it's documented in their medical records that both had a prior history, a long history of substance abuse?
No, I did not review that specifically.
Right. But hypothetically, if they did, and then you found these drugs that you found, they would have tolerance to them, would they not?
That's possible.
I'll permit it.
Could you say that again? I'm sorry?
That's possible.
Right. In fact, Mr. Hayes even had the super powerful carfentanil in his system, right?
It's been asked and answered.
Not in the context of tolerance, Your Honor.
No, it's been asked and answered.
Okay. How would a drug as powerful as carfentanil affect someone's tolerance to opiates?
Well, again, opioid tolerance is developed over time, and it is reversible.
I'm sorry, I didn't
So
you.
a single
Opioid, you said opioid again.
Judge,
So it's
I would object to this line.
Okay, he was answering your question. I agree. Sustained. Finish your answer, please.
Go ahead.
Yes, so opioid tolerance occurs after prolonged use of opioids. However, it is reversible also, so there's no way to measure this individual's tolerance at the time of his death to any opioid. A single use of carfentanil wouldn't create tolerance, but prolonged use over time would.
And again, you're not aware of anything in the medical records that would indicate the prolonged use of drugs like this for either of these people, right?
No.
Okay. Just to clarify, hypothetically, I shoot up carfentanil. Am I not going to be tolerant to it tomorrow?
Objection.
Okay, sustained.
How long till I'm not tolerant to an opioid?
Objection, Your Honor.
Hypothetically, someone with these drugs in their system, how long would it take for them to all of a sudden not be tolerant to that drug?
Okay, that's
Objection, Your Honor.
sustained.
Franklin County has a forensic pathologist, right?
Yes, we have a number of them.
And in fact, isn't it true that it's free, that anyone can request an autopsy?
Objection, Your Honor.
If he knows, do you know whether or not?
I think anyone can ask for an autopsy, whether that does, just because a person asks to have their next of kin autopsies, that doesn't mean that they will in fact be autopsied.
So it's your testimony as the chief toxicologist for the Franklin County Coroner's Office that any citizen with the next of kin that requests an autopsy doesn't get it, there's a process in which they won't get it?
And I say the forensic pathologist manages cases, and they have the discretion as to perform what type of examination is warranted in the case. There are private hospitals that can provide autopsies if the case is not within our jurisdiction or realm.
Okay. Public hospital like Mount Carmel West in Franklin County, right?
Objection, Your Honor.
Do you know where Mount Carmel West was when it existed?
I believe so, on Broad.
In Franklin County, right?
I believe so, yes.
In your jurisdiction, right?
Yes.
Okay, so establishing that it's in your jurisdiction.
No, that's not what that means. When I say jurisdiction, cases that are examined at the coroner's office need to be suspicious deaths, have trauma or foul play involved, motor vehicle accidents, workplace incidents. It is very specific types of deaths, not just that someone died in Franklin County.
Okay, let's go off of what you're saying then about the suspicious deaths. These two people you reviewed were suspected overdoses prior to going to the hospital, right?
Correct.
Okay. And you only are here to testify about two of 14 different people, right?
How would he know that? Rephrase.
Were you ever asked to do this type of analysis for anyone else besides these two people?
No.
And again, it was because their death was related to an overdose prior to getting to the hospital, right?
Yes, that's how the case was presented to us, yes.
Nothing further.
Redirect? Okay, you may step down. We'll go take lunch, ladies and gentlemen. Let's do an hour and 15 minutes, come back at 1:15. Okay? Remember the admonition? We'll get started promptly.
All right.
Have a great lunch, guys.
Thanks.